This conference will now be recorded. This conference will now be recorded.
Am I audible? So today our topic is discussion of the basics of parathyroid gland. So coming to the parathyroid glands, there are four in number. Pair of superior parathyroid glands and a pair of inferior parathyroid glands located in close relation to thyroid gland. So they are normally in color. Some people say golden yellow. Some people say yellowish brown in color. Four tiny little glands which resemble the appearance of fat during section. Even on imaging, it is tough to differentiate these tiny little structures from a lymph node, from an active lymph node or fatty tissue. These tiny little glands, their main function is they can control the calcium homeostasis. So any defect in these tiny little glands can lead to various manifestations of hyperparathyroidism or hypoparathyroidism. So two pairs of parathyroid glands, superior and inferior. You need to remember the type of parathyroid glands. Superior parathyroid glands, they originate from the fourth pharyngeal pouch. So the inferior parathyroid gland, they originate from the third pharyngeal pouch. So this after originating from the fourth pharyngeal pouch, superior parathyroid glands, though initially they are located below the upwards and the inferior parathyroid glands along with the thymus gland, they descend downwards. So inferior parathyroid glands and thymus, both of them, they arise from the third pharyngeal pouch. Most commonly, inferior parathyroid glands are located in close relation to the inferior pole of the thyroid. So mostly the blood supply is from blood supply to both of superior and inferior parathyroid glands. Both of them arise from inferior thyroid artery. So roughly each gland is about 30 to 50 milligrams. So you can look how tiny these are, and 3 to 5 mm in size. Most of the blood supply is from the inferior thyroid artery. So in cases of thyroidectomy, previously we have already discussed. Uh, Nowadays, nobody is ligating the trunk of the inferior thyroid artery. So they're ligating only the capsular branches to the inferior pole of the thyroid in case of a thyroidectomy, thyroid lobectomy or total thyroidectomy, mainly to preserve the blood supply to the parathyroid glands which originate from inferior thyroid. So suppose if you ligate a trunk of the inferior thyroid artery, then there may be chances of poor blood supply and ischemic damage to the parathyroids. So better is to ligate the capsular branches of the inferior thyroid artery while performing a thyroidectomy, dissecting the lower pole of the thyroid. So in 20% of the cases, superior thyroid artery, it also supplies the superior parathyroids. Venous drainage is to the thyroid veins. So one important point you again need to consolidate is superior parathyroid, it originates from the fourth pharyngeal pouch and descends upwards, whereas inferior parathyroid gland, it develops from the third pharyngeal pouch and descends downwards along with the thymus gland. So these this comes under the basic embryology of parathyroid glands, which you need to remember. So the superior parathyroid glands are more or less constant in their position. The position of inferior parathyroid glands are variable. The reason is uh, inferior parathyroid glands along with thymus gland they descend while the thymus reaches the mediastinum. The thymic tract, which is the connection between the thyroid gland and the thymic gland, through which it descends. So these inferior parathyroid glands, the location can be extremely variable. To the location where it reaches the thymus gland, it could be located in the thymus also, in the superior mediastinum also. It could be located in the thyrothymic tract along which it descends. So the variability is more in case of the location of inferior parathyroid glands. So the main stimulus for parathyroid hormone secretion is a low concentration of calcium in the blood. So any hypocalcemia it's calcium sensing receptors. So there will be release of the parathyroid hormone. Parathyroid hormone it acts in the bone, it acts on the renal tubule, and it also acts on the GI tract. So the three sites of action of parathyroid hormone is one is the bone, the other is the GI tract, and the other is renal tubules. So GI tract it enhances the absorption of calcium from the intestine, from the diet which we intake. So parathyroid hormone, its main role is to increase the serum calcium in calcium homeostasis. So it causes increased osteoclastic activity and it causes a flux of calcium from bone. So bone resorption takes place. So there will be bone resorption and increased calcium concentration. So in cases of renal tubules, it acts on the renal tubules and it results in 1-hydroxylation of vitamin D. So first, after vitamin D, uh, cholesterol is very vitamin D3 through sunlight. It travels through circulation and reaches the liver, and it gets hydroxylated at the 25 position. So this 25 hydroxyl vitamin D then reaches the kidney. Then the second hydroxylation, 1 alpha position takes place, and then the resultant active form of vitamin D calcitriol formation. So and it also decreases the loss of calcium in the urine. These are the various sites and action of parathormone. The antagonizing hormone is calcitonin, which is secreted by the parafollicular cells. Parafollicular cells are C cells in the thyroid. So the skin, if you look at this flowchart, you could clearly understand the skin in the UVB light. So pre-pro vitamin D3, which gets hydroxylated and released to pre-D3. So this is vitamin D3 is limited in dietary resources. It mostly arises from sunlight. So this vitamin D3 reaches the liver where it undergoes first 25 hydroxylation. So it converts in 25 hydroxylase of D3 and then it reaches the kidney and here it is hydroxylated at 1 alpha position. So the 1 and 25 position the hydroxylation occurs and then it reaches the for its mechanism it reaches the bone and intestine. So the intestine is it increases the calcium and phosphorus absorption, whereas in cases of bone it mobilizes calcium stores. So the normal level of calcium is 8.5 to 10.2 milligrams per dl. The most important you have to look for is ionic calcium. So this ionic calcium range is roughly about 4.6 to 5.2 milligrams per deciliter. So in cases of investigating hypocalcemia or hypercalcemia, in case of hypocalcemia, you need to first verify the albumin level, and then you need to associate it levels. False positive results of hypocalcemia can occur. So most of it is bound to plasma proteins, and 15% it is conjugated with citrate or the phosphate, and the rest it is in ionized position. Function is a contraction of the muscles, and in the coagulation cascade, this is transport of calcium. So in malnourished, volume overload will be there. Plasma proteins decreases. So the decrease in total calcium level is seen, but ionic calcium level remains same. Just wait for 1 minute. The system is getting hanged. So the plasma protein decrease, there will be a decrease in total calcium level, but ionic calcium level remains same. So ionic calcium level needs to be verified in cases of hypocalcemia to verify to confirm the diagnosis of hypocalcemia. So it is known as pseudocalcemia. So you need to verify albumin level, plasma protein levels of albumin along with the calcium levels. Both you should check simultaneously. So otherwise there are more chances of pseudohypocalcemia. So it is also related to the pH levels. So in acidosis, calcium cannot bond to plasma proteins. In alkalosis, the converse calcium will be there will be more affinity to bound to plasma protein and can cause symptomatic hypocalcemia. So hypocalcemia we already discussed 8.5 to 10.2 is normal calcium level, total calcium level. Less than that, less than 8.5 is termed as hypocalcemia, or ionic calcium level less than 4.5 mg per dl. So the main cause of main cause includes hypoparathyroidism, that is under secretion of the parathormone, vitamin D deficiency. So in inverse relationship with phosphate. So increase phosphate levels, they can decrease calcium absorption. Other than this, in acute pancreatitis, there will be sequestration of calcium in the pancreatic region. So it will lead to hypocalcemia. Drugs like calcitonin, which is the antagonist of parathormone, and bisphosphonates. So the symptoms of first is there will be perioral numbness. So perioral numbness means there will be numbness and paresthesias, and in that is the first sign, and later it can lead to muscle cramps and corporeal spasm. In severe cases, it can lead to tetanus and seizures. So the main signs include signs of hypocalcemia, which you need to observe in case of clinical examination, include Chopstick sign and the Trolley sign. So if you look at this weight, so eliciting a Chopstick sign, you use your finger to tap around the region of inferior to the tragus. Patient should be asked first. The patient should be asked to relax his facial muscles. You stand in front of him and using your finger, just tap it, tap your finger anterior to the earlobe, below the zygomatic cords or below the tragus, so the corner of the mouth. So this is the region where this stylomastoid foramen and all facial nerve reaches. The positive response includes switching of the lip at the corner of the mouth, and in spasm of all facial muscles depending upon the severity of the hypocalcemia. This is close sign. Process sign is uncomfortable and it's painful. So you take sphygmomanometer to the patient arm using uh, the cuff is inflated to roughly 20 to 30 millimeters of mercury pressure above the level of patient normal systolic blood pressure. Suppose if the patient normal systolic there is 130 millimeters mercury, you have to inflate the cuff till 150 to 160 millimeters of mercury for you to observe the pressure sign. So it could lead to the this high blood pressure can occlude the blood flow to that particular region. So this is the classic picture of process sign. There will be carpopedal spasm, wrist is flexion. There will be flexion at the metaphalangeal joints and interphalangeal joints, adduction of thumbs and fingers. So this picture depicts it all. There is flexion at the wrist, and then there is a flexion of the metacarpophalangeal joint, and then extension at the interphalangeal joints, adduction of the thumb and finger. So the treatment of hypocalcemia includes first we need to assess albumin levels also. We need to confirm whether it is not a pseudo hypocalcemia by checking. So in the flowchart, the first line itself is hypocalcemia. The level is adjusted for albumin. Leads to serum estimation of serum PTH. If it is low or normal, you need to check magnesium levels. If it is high levels of serum parathyroid hormone, then you need to check urea and creatinine. So if the serum PTH is low or normal, you first thing you need to verify is the magnesium level, which could also cause similar symptoms. So the magnesium deficiency or hypothyroidism, there could be the calcium sensing defect means calcium sensing receptor can be defective, or in cases of if the serum parathyroid is high, you need to assess for urea and creatinine. If these are high, it could be due to renal failure. So hyperparathyroidism secondary to renal failure can be seen, secondary and tertiary. Then you need to look for 25 hydroxy vitamin D. If it is low, it is vitamin D deficiency. If it is normal, then pseudo hyperparathyroidism calcium deficiency. So the treatment part, coming to the treatment part, first the treatment part includes treating the underlying cause. First you need to treat the underlying causes, whatever it may be. Treating the underlying cause can help in correction of hypocalcemia. If it is mildly asymptomatic, then oral calcium 1000 mg per day, either in a tablet form. If it is severely symptomatic, in, in mild asymptomatic cases, you need to supplement the patient with calcium 1 gram per day. So if the patient symptoms doesn't resolve, you need to add vitamin D3 also. So calcium D3 formulation. So the calcium 1000 mg along with vitamin D3 together should be added to the patient's regime. In severe cases, instead of oral, you will give IV calcium gluconate. Calcium gluconate which should be slowly in 10 minutes by verifying the patient pulse rate. If the calcium gluconate, in cases if it is administered fastly, it could lead to severe cardiac arrhythmias. So, intravenous calcium gluconate should be administered slowly over a period of 10 minutes. So, while administering calcium gluconate, you need to monitor the patient's pulse rate and other things. If the patient is having symptoms of cardiac arrest, calcium chloride form is preferred to calcium gluconate. So coming to hypercalcemia is as it is 8.5 to 10.2, so more than 10.2 is known as level of total calcium. It is known as 10 point hypercalcemia. or ionic calcium more than 5.2. So most common causes includes hyperparathyroidism, hypersecretion of parathormone. Management is mild. If it is mild, you could manage it by hydration. Hydration means roughly you need to infuse the patient to about 100 to 200 ml of normal saline per hour. So to promote the increased forced saline diuresis, the concept is forced saline diuresis. Means you are infusing patient with more amount of saline. So to increase the diuresis, to increase the urine output through calcium. It is mild, it is managed through hydration. So once the patient's intravascular volume reaches a normal status, uh, then you need to add a loop diuretics like a furosemide for the patient to excrete more urine to promote a renal excretion of calcium in case of hypercalcemia patients. So the other thing is you could use calcitonin, but the half-life of the calcitonin is very limited, so the effect is not prolonged. So one more drug which you can use is malignancies and all. The drug is bisphosphonates. These are the drugs which help management. Suppose in case of parathyroid, mostly primary hyperparathyroidism, it is due to a solitary parathyroid adenoma. Rarely it could involve other gland also. Rarely more than one gland. Mostly two glands can be involved. The main management includes first you need to isolate the gland which is hypersecreting, which is having parathyroid adenoma. So the localization studies include 4D ultrasound, focused ultrasound, and 4D computed tomography, and other nuclear medicine scans like system EB scan, NIPA system EB scan. If it is used along with the thyroid tracer, it could lead to good results. These help in preoperative localization of the parathyroid gland, which is secreting more parathormone. So, so then previously the surgical management of hyperparathyroidism used to be traditional four gland exploration. Means you open the patient's neck, go to all the strap muscles after raising subplatysmal flaps and all, dividing, retracting the strap muscles. Then you need to identify the most common locations, four gland exploration. Now with adequate preoperative radiological imaging and good quality of imaging, preoperatively the diagnosis is being known, and it also helps in preoperative localization of parathyroid, right? So as we already know, inferior parathyroid glands which are more variable in their location. So preoperative localization helps in excision of the gland. You also need to monitor the parathormone levels while performing on the patient. So intraoperative parathyroid hormone status proposed by George Irving. So after excising the gland responsible for the hypercalcemia, there should be more than 25%, 25 to 75% drop within 5 to 15 minutes of time period. So this monitoring of IPTH levels, so the intraoperative PTH levels by radioimmunoassay, if these are monitored, the gland responsible for the hypersecretion of the parathyroid hormone can be identified and parathyroidectomy can be done. So these are the most common. It is nowadays there are minimally invasive methods for parathyroidectomy, which could be done using bilateral robotic surgeries and laparoscopic surgeries by axillary. There is a bilateral by axillary approach, and then there is an approach through the neck and few of the cases they are also doing nodes means natural orifice transluminal endoscopic surgery. So they are using transoral route for the secretion of the removal of either thyroid or parathyroid glands. So there are minimally invasive methods also for parathyroid gland surgery. So various common locations could be they could be like superior parathyroid glands. Mostly the constant landmark which you need to remember in cases of parathyroid surgery is the intersection point between the recurrent laryngeal nerve and inferior thyroid artery. So suppose if we draw a circle of 1 centimeter radius along the taking that intersection point as the center of the circle, if we draw a circle, most of the superior parathyroid glands and some of the inferior parathyroid glands can be identified in this circular region. So it could be located anywhere. So in very rare cases, the, these parathyroid glands could be located in the superior or anterior mediastinum and in the thyroid tract. Rarely, the parathyroid glands can also be located intrathyroidally. So in these cases, you need to perform the thyroidectomy, hemithyroidectomy. The lobe, some are located in the carotid sheath. So the location of the parathyroid gland is very much variable. So preoperative localization of the parathyroid gland plays an important role in parathyroid surgery. So now we have finished basic anatomy and physiology of the parathyroid glands. Now the most important topic comes in hyperparathyroidism. One is primary and secondary. There is also a tertiary. So primary means unregulated overproduction of a parathormone with a normal or suppressed PTH levels. Secondary means this hyperparathyroidism is secondary to some other disorders, most commonly due to kidney disorders, renal failure. So coming to the primary hypertension, it is defined as hypercalcemia in the presence of elevated level of PTH. Though the PTH, so the abnormal parathyroid gland, as I already mentioned, I discussed with you, the most common cause of primary hyperthyroidism is solitary overfunctioning parathyroid adenoma. So most commonly it is sporadic. Rarely the hyperthyroid the familial cases. In familial cases, you need to rule out MEN syndrome, MEN1 and MEN2A. And there is also a cluster of familial hyperparathyroidism in familial history. Apart from these two syndromes of MEN1 and 2A, most commonly it is single parathyroid adenoma. Rarely it could be double. Triple is very much rare. So most commonly it is due to parathyroid hyperplasia. There are rare cases it could be due to parathyroid calcemia. So the most common age of presentation is patient third or sixth decade. So it is female preponderance. So multiple cases of neoplasias between MEN1 and MEN2A. So MEN1 components include parathyroid adenoma, pituitary adenoma, and pancreatic islet cell tumor. MEN2A, it is parathyroid adenoma is common, and then there is thyroid medullary carcinoma and pheochromocytoma. MEN2A also known as sickle syndrome. Whereas MEN2B, you also look at medullary carcinoma will be 100%, and there will be neuromas and pheochromocytoma. So mainly men 1 and men 2A are associated with the hyperparathyroidism. So the most common symptoms of primary hyperparathyroidism includes mostly fatigue. There will be musculoskeletal muscle aches or bone pains. Renal, there will be polyuria, so gastrointestinal symptoms include nausea, vomiting, and constipation. In severe cases, there will be psychosis or mood swings and poor concentration. So the manifestations include increased parathyroid hormone, could lead to bone resorption, could lead to osteoporosis and osteopenia and pathological fractures. Renal increased calcium could lead to renal stores. So the nephrocalcinosis. Bone, the most common manifestation includes osteoarthritis, fibrosis cystica, chronic fever, and there will be salt and pepper appearance of skull erosions. So coming to hypercalcium crisis, when it is greater than 3.5 millimoles per liter calcium level, it could be cause hypercalcium crisis. So it is elevated serum calcium level with end organ damage. So most commonly seen in patients with untreated primary hyperparathyroidism and underlying malignancy which are overprotecting parathyroid hormone releasing peptide PDHRP, which is paraneoplastic syndrome in case of lung carcinoma, skin carcinoma, and squamous cell carcinoma of the head and neck and esophagus. So management includes aggressive fluid resuscitation. So when the patient blood pressure returns to normal and the intravascular fluid level is normal, you can add loop diuretics like furosemide. In severe case of renal failure, the patient should undergo dialysis. So the glucocorticoids can be used. If it is malignancy, it is ineffective. Otherwise, glucocorticoids potentiate the effect of uh, potentiate the increased accumulation of calcium. And in case of malignancy, bisphosphonates, calcitonin, as we already discussed, its half-life is low, so a limited effect while switching over to bisphosphonates. So coming to secondary hyperparathyroidism, the derangement in calcium homeostasis second leads to a compensatory increase in PDH secretion. So it is most commonly due to chronic kidney disease. So it is secondary because a disease which is outside the parathyroid, causing the parathyroid glands to become hyperactive. So the common cause of etiology we already discussed. Most important is the chronic kidney disease, and in rare cases it could be lead to because of severe vitamin D deficiency and GI malabsorption such as celiac disease and short bowel syndrome, chronic liver disease, and one more important drug is chronic lithium usage and aluminum toxicity. Is in patients with chronic kidney disease. For this chronic kidney disease, they fail to convert the vitamin D to its active form by 25 hydroxylation in the do not exclude phosphate. So this increased phosphate could lead to decreased calcium and all. This secondary it leads to increased hyperparathyroidism. So pathological characteristics asymmetric enlargement or nodularity. When the parathyroid gland it becomes nodular, it loses the of vitamin D and calcium receptors. So this flowchart clearly conveys altered calcium homeostasis in case of chronic renal failure, while leading to renal osteodystrophy and hyperparathyroidism. So the chronic renal failure leads to impaired excretion of uric acid and urea, leads to acidosis and uremia. So phosphate excretion are also impaired, so there will be increased phosphate hyperphosphatemia, which increase the phosphate levels, decrease the calcium binding, so leads to hypocalcemia. So chronic renal failure, we already discussed. There will be impaired 25 hydroxylation, converting the vitamin D into its active form. So this leads to skeletal parathyroid resistance and impaired GI absorption of calcium. All this leads to hypocalcemia. This hypocalcemia, because of calcium sensing receptors, the serum level will be less. So this activates the parathyroid gland to secrete more parathyroid. So this is constitutes secondary hyperthyroid. This acidosis and together with impaired formation of active vitamin D leads to renal osteodystrophy. So the factors contributing to the pathogenesis include phosphorus and calcium. They continue to be resolved. Increased phosphorus and fibro growth factor, 1 and 25 hydroxylation of vitamin D leads to decreased calcium absorption. So decreased calcium absorption leads to decreased serum calcium, hypocalcemia, which senses and decreased PDR activation and calcium sensing receptor activation. So all these leads to increased parathyroid hormone secretion. So this secondary changes cause glands to overfunction by parathyroid gland hyperplasia. If the gland becomes nodular, there will be decreased sensing of receptors, increased bone reception. This cycle contributes to secondary hyperthyroidism. So there is one more entity known as tertiary hyperparathyroidism. It is a state of excess secretion of parathyroid hormone after a long period of secondary hyperparathyroidism resulting in high blood calcium level. So tertiary hyperthyroidism leads to autonomous overfunction of the parathyroid gland in case of long-standing case of secondary hyperparathyroidism. So it is seen more common in patients with secondary hyperparathyroidism who are on dialysis therapy for years together. This hypertrophied parathyroid glands enlarge over time. After enlarging, they become autonomous over time. Despite the serum levels are normal, they continue to overproduce because these enlarged glands they have become autonomous and don't respond to the feedback mechanism of endocrine system.